Hello everyone. Today I've put together some important tables from TOG articles to help with your MRCOG Part 2 revision. I hope you'll find this useful. Don't forget to give it a thumbs up and leave a comment if you like this sort of format of videos. Right, so the first table is a summary and examples of classification of differences of sex development. So 45XO is Turner syndrome, 47XXY is Klinefelter syndrome, and there is others like 45 or X46 or XY, which is mixed gonadal dysgenesis or over-testicular differences of sex development. 46XY disorders are disorders of the gonadal development, like gonadal dysgenesis, example in Sawyer syndrome, disorders in androgen synthesis or action, so 5-alpha reductase. Then you have the complete androgen insensitivity syndrome. You've also got the partial androgen insensitivity syndrome. You've got 17 beta hydroxy steroid dehydrogenase deficiency, and you've got the LH receptor defects. You've also got cloacal extrophy. So 46XX disorders, so disorders of gonadal development, or gonadal dysgenesis again, testicular or over-testicular DSD, androgen excess, so congenital adrenal hyperplasia, exogenous and androgens, and others like cloacal extrophy or Mullerian duct anomalies. Right, so this is quite a useful slide as well because it tells you exactly why you need the different conversion pathways in order for certain, active compounds to be produced, and why this is important, and how defect in one of these pathways can mean that there'll be a problem with metabolism of that particular steroid. So you've got your mineralocorticoid pathway, glucocorticoid pathway, and sex steroid pathway. So you've got, as you can see, there's multiple enzymes involved at every stage of the pathway in order for this pathway for it to be a success. So for example, if we take pregnenolone is converted to progesterone by 3-beta OHD hydrogenase, and then which is then converted further to by 21 hydroxylase to 11 deoxy corticosterone, which is then converted to corticosterone by 11 beta hydroxylase, which is then converted to 18 OH corticosterone by 18 hydroxylase, and then finally converted to aldosterone by 18 OH hydroxylase. And you can see how if one component was missing or defective, how this whole pathway could be disrupted. Similarly, you can see pregnenolone can be converted to 17 hydroxy pregnenolone by 17 alpha hydroxylase, which is then further converted to DHEA, which is dihydroepiandrosterone, by 17 alpha hydroxylase, which is then further converted to androstenedione and then testosterone. And you can see in that final step where testosterone is converted into dihydrotestosterone, the enzyme that's required is the 5-alpha reductase, and if there's a deficiency within it, then you don't get that active component of the testosterone, and that can be defected. Similarly, you can have deficiencies of 17 beta OH dehydrogenase, which is useful in converting the androstenedione to testosterone. So you can see if that's missing, then you're going to have problems with active components of testosterone being produced as well. So quite a useful little chart to show you the importance of the different pathways. Right, types of ovarian cysts and neoplasms in children and adolescents. So benign can be simple cyst, it's the majority, 60%. Complex cyst can be mature cystic teratomas, endometriomas, gonadoblastomas, serous cystoadenomas, mucinous cystoadenomas, cystoadenoma fibroma, ovarian torsion, tubovarian abscess, paratubal and parovarian cyst. Malignant is 4 to 16%. Sex cord stromal tumors, genital granulosa cell tumors, most common, Sertoli Leydig cell tumors, germ cell tumors, germinomas, yolk sac tumors, embryonal carcinomas, polyembryoma, immature teratoma, epithelial tumors, serous adenocarcinoma, and mucinous adenocarcinoma. So we then move on to the B rules and the M rules. I'm sure you've all heard about the B rules and the M rules in your careers so far. B rules are for benign features, M rules are for malignant features. So if a cyst has B rules mostly within it, then it's likely to be benign. If it has M rules within it, and this is during ultrasound, then it's likely to be malignant. So B rules are things like unilocular cyst, presence of solid components with largest being less than 7 millimeters, presence of acoustic shadowing, smooth multilocular tumor with largest diameter of less than 100 millimeters, blood flow absent on Doppler. M rules are irregular solid tumors with ascites, with papillary strictures, at least 4 of those, irregular multilocular solid tumors with largest diameter greater than 100 millimeters, and very strong blood flow present. Tumor markers and associated ovarian neoplasms. So if alpha fetoprotein was raised, then as that's associated with immature teratomas, Sertoli and Leydig cell tumors, yolk sac tumors, embryonal carcinomas. Human chorionic gonadotrophin, so dysgeminoma, embryonal carcinoma, lactate dehydrogenase, so dysgeminoma, immature teratoma. CA1 to 5 is epithelial tumors, chorioembryonic antigen is epithelial tumors, estradiol is genital granulosa cell tumor, and testosterone is Sertoli Leydig cell tumors. Note that alpha fetoprotein does also go up in Sertoli Leydig cell tumors as well. Right, so then we move on to how to manage cysts in children. So referral and presentation of ovarian cysts. If the patient is asymptomatic or they do have pain in abdomen, menstrual problems, precocious puberty symptoms, transabdominal ultrasound should be done. If it's a simple cyst between 3 and 5 centimeters, then rescan in 3 months for reassurance. If the cyst is 5 to 7 centimeters and they're asymptomatic, then rescan in 3 months. And if it resolves, fine. If it persists, then tumor markers and MRI should be done, and and then based on that, you would then guide further management. However, if they had a simple cyst which was 5 to 7 centimeters and symptomatic, you would then do tumor markers and MRI. You would then do laparoscopic ovarian cystectomy or rescan in 3 months if patient is asymptomatic. You after scan, if it proves to be a complex cyst, so if the cyst is greater than 7 centimeters, then you directly go on to laparoscopic ovarian cystectomy or rescan in 3 months. Can be considered if asymptomatic. So if it's a complex cyst tumor and you do tumor markers like alpha fetoprotein, beta-HCG, lactate dehydrogenase, CA1 to 5, MRI, and if it's suspicious of cancer, then gynecology, MDT, and oncology review is advised. If there's no suspicion of cancer, if it's symptomatic, size more than 5 centimeters, then laparoscopic cystectomy is advised. All children and young girls should be followed up after surgery to discuss findings and implications on future fertility. If the patient was seen with a cyst in emergency department with suspicion of torsion, then imaging to confirm to inform surgery if available within 4 hours of admission and clinical condition permits, and then laparoscopic surgery where possible, ovarian sparing surgery. Request on-call gynecologist for input. Right, so surgical tips for laparoscopy in children and adolescents. So what is it that we should be careful of in children? So anatomy, so bladder is intraperitoneal in children, so care with suprapubic ports. Age less than 10 years, catheterization can cause urethral trauma. Thin child will have aorta just beneath the skin. Careful with skin incision and lift up the umbilicus before incision. Pneumoperitoneum is kept at 12 to 15 millimeters for thin adolescents. Younger children may require 8 to 10 millimeters of mercury pressure settings. Fascia is not well developed and prone to port side herniation. Use smaller scopes, 2 to 5 millimeters. Use small trocars. Close the fascia 10 millimeters and more port side. Keep camera in the port as the umbilical port is removed to prevent mental evisceration. Keep port open while removing. Avoid vaginal examination and uterine manipulation in adolescents unless necessary during procedure. With the anesthesia, be mindful of the effect of intraperitoneal carbon dioxide under pressure and limited functional lung capacity. So adapted from the World Health Organization. So you've got classification of non-epithelial ovarian neoplasms. So you've got sex cord stromal tumors. So they can be divided into the pure sex cord tumors and the pure stromal tumors. So and then the mixed sex cord stromal tumors as well. So pure sex cord are granulosa cell tumor, adult type, juvenile type, Sertoli cell tumor, sex cord tumor with annular tubules, and then the pure stromal tumors are the fibromas, the thecomas, the fibrosarcomas, the Leydig cell tumors, the sclerosing stromal tumors, the signet ring tumors, the steroid lipid cell tumor, the Leydig cell tumor, and then you've got the mixed, which is the Sertoli Leydig cell tumors. Germ cell tumors are teratomas, immature, mature, embryonal carcinomas, non-gestational choriocarcinomas, dysgeminomas, yolk sac tumors, and mixed germ cell tumors. So monodermal teratomas and somatic type tumors arising from dermoid cysts, including malignant stroma ovary, malignant neuroectodermal tumors, and sebaceous carcinomas. Miscellaneous tumors, including small cell carcinomas, hypercalcemic type, and small cell carcinomas pulmonary type. Soft tissue tumors like myxomas, others including angiosarcomas, lymosarcomas, liposarcomas, and osteosarcomas. Right, so this table talks about which tumor markers go up in which type of tumor. So dysgeminomas, you have raised LDH. Embryonal, you have raised HCG, plus or minus LDH, plus or minus alpha fetoprotein. Immature teratomas, plus or minus alpha fetoprotein, but there will be no HCG, and plus or minus LDH and plus or minus DHEA, which is dihydroepiandrostenedione. Then you have those immature teratomas that we talked about, and then choriocarcinoma is HCG plus or minus LDH. Yolk sac tumor is alpha fetoprotein plus LDH, and then you have your thicoma, which is plus or minus inhibin. Granulosa cell is inhibin plus or minus T, which is testosterone, and then you have your Sertoli Leydig cell tumors, which is plus or minus testosterone, plus or minus inhibin, plus or minus DHEA, plus or minus alpha fetoprotein, and plus or minus androstenedione. I hope you found those little summary of tables useful, and if you did, don't forget to give this video a thumbs up and leave a comment. I will continue to do more parts of such useful tables from the various different TOG articles as well. So do let me know if you found this useful. I hope that your revision's going well, and good luck for your exam.